Welcome back, ladies and gentlemen. We are resuming the proceedings of the 49th Sri Lanka Surgical Congress, the annual academic sessions of the College of Surgeons of Sri Lanka. Next in line, we have the plenary discussions. So the first plenary is titled Resuscitation Physiology in Trauma. So this will be chaired by Dr. Ranjith Ellawala. He is the Consultant General Surgeon and the Senior Lecturer at the Ellawala Defence University of Sri Lanka. Over to you, sir.
Very good afternoon to you, all of you, and welcome to the first plenary session of our annual Congress. Joining us from Johannesburg is Professor Kenneth Boffard, who is a leading trauma surgeon, and he's also an honorary fellow of the College of Surgeons of Sri Lanka. He has been the live wire of our trauma training, contributed to train more than 30 trainers in NTMC over the last 12 years. He'll be speaking to you on resuscitation physiology. Now let's listen to his video recording.
Good afternoon. On behalf of the International Society of Surgery and our partnership with the College of Surgeons of Sri Lanka, thank you very much for the honor of being able to be present, if only virtually, and I look forward to even more successful congresses in the future in association with the Sri Lankan surgeons and my hosts, the President and Dr. Ranjith Ellawala, who is hosting this session. I've been asked to talk about resuscitation physiology, and the reality is that if we are going to resuscitate anyone, there's a certain necessary entry level of what is required. You need a team capable of understanding the roles of each individual. Over and above that, the ability to achieve specific tasks and understand the physiology of the body in order to develop a response with certain goals that everyone has in mind. Resuscitation is not for the faint-hearted. There's a whole bunch of complications and all sorts of things waiting for you even if you get to the side of the water. Resuscitation needs a number of calm people, all knowing and respecting each other. Some of you may once remember a pilot unfortunately hit birds shortly after taking off from LaGuardia Airport, and I'd like to play you the tape of what happened when that occurred.
1549, 700, landing 5,000.
Cactus 1549, report to the contact on maintain 15,000.
Maintain 15,000, Cactus 1549.
Cactus 1549, turn left lane 270.
This is Cactus 1539, hit birds, so you're lost thrust on both engines, returning back towards LaGuardia.
Okay, you need to return to LaGuardia. Turn left heading up 220.
220.
Tower, stop your departures, got emergency returning. It's 1529. He bird strike. He lost all engine. He lost the thrust in the engines. He's returning immediately.
Cactus 1529. Which engines?
He lost thrust in both engines. He said.
Got it.
Cactus 1529. If we can get it to you, do you want to try to land runway 13?
We're unable. We may end up in the Hudson.
All right, Cactus 1549. It's going to be less traffic to runway 31.
Unable.
Okay, what do you need to land? Do you want to try to go to Teterboro?
Yes.
Teterboro, Empire, actually LaGuardia departs guy, emergency inbound.
Hey, guys.
Cactus 1529 over the George Washington Bridge, wants to go to the airport right now.
Wants to go to our airport. Check. Does he need assistance?
Yes, it was a bird strike. Can I get him in for runway 1?
Runway 1, that's good.
Cactus 1529, turn right 280, you can land runway 1 at Teterboro.
We can't do it.
Okay, which runway would you like at Teterboro?
We're going to be in the Hudson.
I'm sorry, say again, Cactus? Cactus 1549, radar contact is lost. You also got Newark Airport off you 2 o'clock in about 7 miles. Eagle Flight 4718, turn left thing 210.
210, 4718. I think he said he was going in the Hudson.
Cactus 1529, you saw him?
Two 2 minutes and 7 seconds between incident and when he got everyone into the Hudson River. He was asked about it afterwards, And they asked him, were you worried about the cabin crew? And he said, I knew that if I did my job, I could rely on them to do theirs. Between us, we would get the job successfully done. They also asked him, did you pray? And he looked straight back and said, didn't you hear what I said? I was doing my job, and I hope everybody else was doing theirs. But he subsequently said something else. He was asked how he managed to get through this extraordinary experience that no one had ever done before. And his answer was in front of you. For 42 years, I've been flying. Every year, I have made a small deposit in the bank of experience. And today, I made a very large withdrawal, but I had the funds to cover it. Doesn't that say it all? A team based on experience and trust of each other can resuscitate an awful lot of things. We start off our story with the oxygen hemoglobin dissociation curve. Most of you are familiar with this, and the oxygen hemoglobin dissociation curve traditionally is that which is responsible for oxygen being delivered by the hemoglobin to the tissues. If there is alkalosis or low temperature, that doesn't happen and the tissues don't get oxygenated properly. Lack of planning for this should not constitute a crisis, but if you don't plan, you will fail. So the resuscitation is quite simple. Everything that we do with airway and with breathing and with circulation requires oxygen from the outside to reach the inside, airway and breathing. It has to come into contact with blood cells in the lungs, be transported from the alveoli to the cell, and delivered to the cell itself, which means the target organ. If you fail to do this, then you get anaerobic metabolism and a rise in lactate. And goal-directed oxygenation revolves around this fact, that if you can get oxygen to the tissues will metabolize, will respond, and will not die. Hemorrhage control takes it one stage further. You need the medium to take that oxygen to the tissues. That's hemoglobin in the cells. The more you bleed, the less the medium that there is. So maintaining blood volume, not exceeding it, but maintaining it is absolutely critical. There are risks and benefits, but the reality is a patient managed with a reasonable circulation will do better than one who isn't. The treatment of bleeding is not replacement. The treatment of bleeding is to stop the bleeding. We can do this with adjuncts as well, stopping the bleeding with local hemostatic agents, including chitosan, which is derived from prawn shells, QuickClot, which is mineral zeolite and is exothermic, and a number of other fibrin products which result in the clot forming more readily and being more adherent. So far, so good. Other adjuncts can be a mechanical plug, either packing the wound, or if it's a penetrating injury, a Foley catheter can be inserted and blown up. Caveat, if you do that, the balloon may not be over the bleeding part, it may not press it, it may just stop you seeing the bleeding. So one needs to be a little bit careful with that. Tourniquets have come back into fashion. They are quick, they are easy, but like most things, they do have a downside. There's no question that the tourniquet saved the top right-hand gentleman from bleeding to death. Unfortunately, the one on the bottom right-hand was applied below the knee when direct pressure was probably better, and left on for 4 to 6 hours, resulting in the loss of the leg. There's no free lunches in this game. We know all about adjuncts such as regional angioembolization and stenting. More recently on the market has come the R.E.B.O.A, resuscitative endovascular balloon occlusion of the aorta. The intention here is rather like a Foley catheter that's been very elongated, balloon is put through the femorals up into the aorta, either at the level of the diaphragm, so-called level 1, or at the renals, or at the bifurcation, and that cuts off all arterial flow below it. It's extremely useful if you have uncontrolled bleeding. Like most things, there are downsides, and if you are expecting to put a R.E.B.O.A into everyone, I think one should be just a little worried as to what the indications. The reality is we have still to decide where it's best inserted. Should it be in the hospital or pre-hospital or in the operating room, all under direct vision or ultrasound? And then for which condition? Blunt fractured pelvis or a gunshot aorta? The trouble is, at the moment, it's a new hammer. It's extremely promising. But there's an awful lot of things that look like nails at the moment. The reality is the best way of stopping the bleeding of all is factor 14 replacement. Hold on a minute. There are only 13 clotting factors. Where does factor 14 come in? Well, liberal application of factor 14, otherwise known as the surgeon's finger, will frequently stop more bleeding than the other 13 put together. Never forget, the treatment of bleeding is to stop the bleeding, not supplement that which is being lost. If you lose too much, you develop a coagulopathy. The commonest cause is actually related to dilution. Its pathogenesis is multifactorial, it's very complex, and vascular injury and hemorrhage causing direct loss of circulating volume, circulating cells, clotting factors, and platelets. The treatment of bleeding is to stop the bleeding. We respond, in fact, by giving transfusion. But there's risks there. Firstly, the relationship between units of transfused blood on your left-hand side goes up. The more you transfuse, the more the incidence of multiple organ failure. On the right-hand side, however, it's not a linear relationship. The incidence of infection goes up exponentially. Blood is bad, more blood is worse. And we know that because there's ample data which says the greater the transfusion, the greater the incidence of mortality, and it's more reliable than the actual injuries themselves. Blood transfusion is like a marriage. It's a wonderful thing to behold, but it should not be entered upon lightly, unadvisedly, or wantonly, and absolutely not more often than is absolutely necessary. Think about it. With 23 potential diseases, clotting abnormalities, and multiple incidents of incorrect transfusion, if we were applied for a license to the American FDA in 2020, would we get one? So the idea is to try and minimize blood transfusion use by minimizing blood loss. And you can do this by optimizing the conditions, making sure that the oxygen being delivered to the cells is as optimally delivered as possible. And there are new products coming on the market, including artificial hemoglobins and so on. Those of you who do not have a massive hemorrhage protocol do need to develop one. That is regarded now as probably one of the single biggest things of saving blood use by not using it wantonly. So what do? We overload our patients. We give them too much. We dilute their clotting factors down. End result, they stop clotting. We take their patients' clothes off. That results in the patient becoming hypothermic and inhibits enzyme reaction to the coagulation cascade. Don't allow the core temperature to decrease below 35, and by the time it comes to 32 degrees, you've actually got a 100% mortality. Are we freezing our patients? Yes, we are. We put on protective clothing, take the patient's clothes off, and put them into an air-conditioned environment. Not a good idea. Keep them warm. Then, are we using the wrong fluids? Well, crystalloids can cause dilution, Colloids are even worse, and chemical coagulopathies that occur particularly with the starches make all colloids completely contraindicated. Plasma, freeze-dried plasma, has a use, but we then resort to blood. Can we reduce the bleeding in other ways? Well, many of you will be familiar with the CRASH 2 study. Very reasonable data showing 20,000 patients with 10,000 got tranexamic acid, 10,000 didn't. But the study was very flawed and is not wholly appropriate. Both groups only received 3 units of blood because that was all there was. The patients all came from developing environments where there was no backup, and there's not even data regarding those deaths as to how they died. In your practice, do you really have a 14% mortality if the patient has 3 units of blood? So tranexamic acid administration is really for selected cases where blood and blood products are not available, possibly in rural or military situations. But it is certainly not a panacea for everything, and you should be very, very selective, because increasing data says DVT and pulmonary embolism are more common. There's a good reason why it is not routinely used in the United States and South Africa. Nowadays, just as we spoke about goal-directed oxygenation, we're talking about goal-directed coagulation. The Thrombo-Elastogram is now the gold standard for all resuscitations, alternatively using rotary thromboelastomorography or ROTEM. Essentially, a cc of blood is agitated with some tissue factor, and the speed with which the clot is assessed. The clotting factors take up to 8 minutes to react with each other, known as the R time, depicted pictorially on the right of your screen. When the clotting factors come and activate factor 13, to activate at 13, platelets are rendered sticky and fibrinogen is converted to fibrin. This kinetic change, or K time, is generally less than 2 minutes. That stage, the platelets then stick to the fibrin strands and the clot is formed. The rate at which the clot is formed is known as the alpha angle and should be greater than 70 degrees. The steeper it is, the more hypercoagulable the patient is. When the clot is formed, the amplitude of the clot can be measured, and that reflects the number of platelets and the strength of the clot. In some people, particularly with dilutional coagulopathy, the clot may lyse. After 30 minutes, it should not have reduced in size by more than 8%. So one can get a visual impression of what clotting factors are needed and when. And if that's a little complicated, don't think of it as a wine glass. On the top left of your screen is a red wine glass. That's a normal thromboelastogram. If you've got clotting factor deficiencies, the stem of the glass gets longer and the actual clot gets thinner, like a white wine glass at the top right. If you are hypercoagulable, like in the middle on the left, or if you have virtually no clotting with thrombocytopenia as well, like the test tube in the middle right. The patient who is coagulopathic looks like the bottom left and requires fibrinogen, platelets, and fresh frozen plasma or cryoprecipitate. And some patients become fibrinolytic, as we spoke about it, particularly those with dilution, no other blood transfusion, and those patients are a bit like a martini glass, need tranexamic acid. So it's very easy now to look at what is missing in the forming of the clot and supplement with goal-directed clotting agents. Most centers find that when they do this, their blood usage drops by up to half for the same results. Baseline bloods, every patient when they come in should have those bloods that are shown and repeated after every 6 units. We do not generally do INRs, PTTs if it's not absolutely essential, and even D-dimers are not helpful. So those in yellow are what are needed if in association with TEG or ROTEM you're doing goal-directed hemostasis. If you do have to transfuse, we recommend either whole blood but generally not available, so packed red cells which are leukodepleted and administered 1:1:1 blood, plasma, and platelets. Your endpoints: no active bleeding, no further need for red cells, warm, not acidotic, normal TEG. Now they're ready for scan. Now they're ready for definitive care. It's not simple, it's not complex, but every member of the team must understand the interaction and the way they work together. Blood transfusion is a last resort, and all your resuscitation must be fully goal-directed. Again, on behalf of the International Society of Surgery and everyone who's contributed toward this, thank you for listening. Thank you for allowing me to take part. Have a great meeting.
And on behalf of the President and the Council of the College of Surgeons of Sri Lanka, let me thank you for this wonderful presentation. And it was an honor and a privilege to have you with us today. And I thank all of you being with us. And now the session is closed.